on to the next presentation by Simona Di Carlo, a psychotherapist who will relate to us about the psychological considerations in patients suffering from Chiari-1 malformation.
Buongiorno. Ho tenuto a sottolineare che
Good afternoon. I would like to highlight that my role is slightly different compared to the previous speakers. I'm a psychologist, a psychotherapist. I've been working with the Besta Institute for 2 years now, and in particular we are in the neurosurgery department. I have the occasion to offer you a complementary point of view, complementary to the typical aspects of the Chiari malformation discussed so far, and I'd like to do it by focusing on 3 points. First of all, I'd like to shed some light on the work we've been doing with patients, and then I will discuss the correlation between Chiari and anxiety, and then I will then discuss the problems related with this kind of disease and with rare diseases in generally, and its repercussion on the identity of the patient. Of course, I cannot relieve symptoms or treat symptoms physically, but there is a psychic pain that needs to be treated psychologically, because these adds up to physical sufferings. And it can worsen symptoms, and it can delay recovery after surgery, and therefore psychological support becomes important to, let's say, face these psychological pains. The psychological support I offer to patients is aimed at finding some time to spend with the patients, so as the patients can discuss and somehow tell me about their history and their story, and about symptoms and things that may not often be done with the doctors. Also because the doctors may not always provide this kind of psychological support, and therefore the role of the psychologist can be very important for the patient. Our support involves the following steps. Patients who come to our hospital know already that will have to undergo surgery, and of course the support is provided during the hospital stay. I cannot always meet these patients before surgery. Often I see them after surgery, and the situation is quite special because besides the problems associated with the disease, there are all the unpleasant feelings associated with having to undergo surgery. For instance, fear for anesthesia, this sort of artificial sleep, which is somehow equated with death, and that evokes death-related feelings in people. And by only naming them or discussing about them, people tend to relax and be more somehow willing to accept surgery. This is a counseling work, actually, that takes place in the hospital, in the aisles, close to the bed of the patients, in talking with parents or with relatives that, of course, need to be included in this psychological support activity. And the idea is to enable patients and relatives to express themselves, so going beyond this, the surgical or the medical activities. So these are the situations in which I met Chiari malformation patients, and what is immediately evident in the words of the patients is that in the vast majority of the cases before achieving the final diagnosis, these patients are diagnosed with psychosomatic disorders, especially anxiety-related disorders or panic attack disorders. This shouldn't be neglected or underestimated because this definitely affects the way the patient approaches his or her own disorders. These are some of the symptoms associated that anxiety and chiari malformation have in common. Headache, fatigue, tingling, and numbness in the extremities, general imbalance, clumsiness. There are many, and oftentimes they are associated with panic attacks. And another observation that stems from the discussions with the doctors is that in general, compared to other diseases including the tumors, Chiari malformation patients show a great concern about themselves, about their well-being, about their symptoms. And this is an attitude that needs to be carefully taken into account, and that led me to try and understand the reason for this concern. Not much can be found in the literature about Chiari and anxiety-related disorders. There are a few studies referring to psychiatric disorders. One is about panic attacks, the other is about anxiety disorders per se. And the authors tend to highlight that in any case the two diseases together can cause confusion and make it difficult to discriminate between anxiety symptoms and neurological symptoms, and certainly further investigations can help out to understand exactly how the clinical picture is in the end. And these studies mainly tried to rule out through surgery to solve neurological symptoms, and then medical treatment or pharmacological treatment was adopted to treat anxiety. But these are only isolated cases, and no study has ever made on a larger sample of patients with symptoms which are not typical symptoms of psychiatric disorder, of psychological disorder. And these authors in particular suggest that neurological symptoms may trigger episodes of anxiety. So this physical pain or physical symptoms that can then activate and trigger anxiety episodes. And then another assumption is that neuroanatomical anomalies caused by the Chiari malformation lead to these subjective feelings of anxiety. Or also, the malformation itself can cause these kind of disorders. The question is there any other specific non-neurological symptoms that can lead to anxiety disorders? Well, research could be made on a larger sample of Chiari patients, in which we could try to discriminate. We could submit them to anxiety tests to understand what is what. I mean, to see what can trigger anxiety, and it would be advisable also to take a sort of snapshot of the personality of every single patient, therefore a personality outline to have indication about the personality structure that can lead or not to anxiety symptoms, and then detailed interviewed about symptoms are advisable as well before and after surgery to better discriminate between neurological symptoms and psychological symptoms. However, as I said, there might be other explanations for this concern of these patients for their health. And these are the observations that I could make when working with these patient, and I'd like to highlight these key features which are very important to me. First of all, this is a chronic disease, and the evolution of symptom is not very well defined. There can be a worsening and then could be an improvement, but in any case the person has this feeling of uncertainty about the evolution of symptoms and knows that we'll have to face and cope with this kind of problems throughout their own life. You should also take into account what happens when a person discovers to have a chronic disease, because I might be an healthy person and I discover all of a sudden that I'm no longer healthy, but I have a chronic disease, and in particular that I have the Chiari malformation. So I have this label on me, and this label should not become the representation of what I am. I mean, I am a person and that has developed this disease, and therefore psychological work on these aspects can enable the patient to better place this disease in his or her life cycle. And this is very important for a person to be able to lead a normal life, and so in order not to be too much affected by this disease. Then, second point, this is a rare disease, and this is another very important element, because being defined as a rare person, you know that you may not share with a lot of people what you have. Not many people know about this disease being a rare disease, and the feeling of isolation that these people experience is sort of multiplied, amplified by the very fact that this is a rare disease. And of course this can have two different outcomes, meaning that on the one side that you may look for people who have the similar experience, so who have the disease, and on the other, the person, you may feel not to be isolated and to withdraw, and so this work, this psychological work, needs to be done very accurately and should not just be limited to discussion on symptoms and treatments. It has to be something more. It has to be a sort of sharing the disease, on experiencing together this disease, so that people do not feel, so to say, encapsulated into that specific definition. I talk a lot with patients, even though there's a difference between adults and children. And also we have to remember that the diagnosis is often made after a long and painful quest for a diagnosis, and these patients tend to go to many different centers and tend to undergo many different treatments. So the patient is virtually fed up already, because the patient may think he's at the end or she's at the end of the process, but actually he or she is at the beginning of the treatment, and so these people are exhausted because now they have to face something new, now that they know what the diagnosis is like. So what can we do from the psychological standpoint. So what kind of support can be offered to these patients? I never talk about psychotherapy because it's up to the person to decide to undergo psychotherapy in case he or she wants to elaborate things in more depth. But if we only focus on the, let's say, on what we do, we actually offer a well-targeted approach, and it is very important for the patient to sort of elaborate all feelings related to this feeling of being ill, being sick, and by elaboration I mean digesting these all these feelings, so trying to find a way to cope and accept, cope with and accept this problem. So we somehow have to integrate this disease and into our life, into our identity, and of course we have to offer. We have to share with patients their problems, but with a very critical and effective approach, and also we have to help the patient to help themselves so that they can comply with the treatment and with the collaborate with the doctors, also because in many cases, after this long process, patients may lack confidence or may be angry about misdiagnosis, and also sometimes these patients may not be very willing to comply with the treatment and to collaborate with the medical staff. Something that I have discovered over the years while working with these patients and families is that we have to support also people supporting the patients, and by this I mean families, because it's not easy to support a person with this kind of disease, and so also therefore relatives or the families in any case need to be given suitable tools to support patients, because this disease involves the entire family, and so must be looked at with a sort of comprehensive approach, because this disease affects the entire family. Every single member of the family needs somehow to elaborate or to face and cope with the disease somehow. And also a special thought needs to be given to parents who have to face the disease at various levels. Not only do they have to physically support the child or the son or daughter, but they also have to make decisions about their children's health. And of course the parents also experience this sort of narcissistic scar or problems of not having offered all to the child, and so they are often confused and uneasy, and so they need to be supported so that the child in the end can face the situation. Thank you very much. Dr. Di Carlo, is there any question about this special slant, special aspect? I think I understood from your analysis that Chiari malformation children compared to children with other neurosurgical disease experience more anxiety. And I'd like to know whether there are also other differences between these children and other children, and also if you notice the differences between children that come to your department only for tests, always of course with chiari malformation, and the children that are scheduled for surgery. And also I'd like to see whether you identified differences in terms of psychological outcome between patients operated for chiari malformation and patients operated for other diseases. First of all, this anxiety problem most affects adults because children have different problems, as we saw this morning, that are assessed differently. What I have noticed, so what I have observed, but not validated, of course, so this is just the result of my observations with my patients, is that in the young children, let's say primary, secondary school age, these children tend to isolate themselves because of the symptoms they experience. For instance, a child with a constant or chronic headache will tend to avoid situations where there is a lot of noise or situations in which there could be confusion or chaos, and so will sort of be more withdrawn and will tend to be less willing to stay with peers. And I have seen a few cases also of difficulties at school with some children. So some of these children do not want to go to school because of these symptoms. So these are the main features I could identify, I could observe by listening to patients and to parents. As far as the comparison with other children that undergo surgery for other reasons, this is the main difference. When there is surgery involved, I often focus on trying to accompany children towards surgery and parents towards surgery adequately and to reassure them. And so I try to explain to them that this is something quite normal, and so I mostly focus on, let's say, the surgery-related problems.